Hi, I'm Game Nikita. Welcome to my channel. Today I'll be doing part 2, skin manifestations in pediatrics. In part 1, I spoke about neonatal skin manifestations, and now in part 2, I'll be talking about newborn and infants. This section will be addressing capillary hemangiomas, eczema, which has endogenous and exogenous types, oral thrush, and neonatal varicella. Newborn and infants. Now, capillary hemangiomas are very common, especially in preterm infants. They are benign and non-cancerous, and on inspection you would see bright red lumpy lesions and they're caused by proliferation of blood vessels. They enlarge up to the age of 2 to 4 years and then regress thereafter. That is, they resolve spontaneously. But if the lesions are near the airway or the eyes, injection with steroids may speed the regression, and the definitive treatment is the use of propranolol. Here's a picture of capillary hemangiomas. As you can see, I used pictures with the lesion around the eye area just to remind you that if the lesion is in the eye or in the airway, it can cause serious complications. Eczema. Eczema is usually associated with inflammation of the skin, and so the terms eczema and dermatitis are often used interchangeably because dermatitis simply means inflammation of the skin. The condition may be induced by a wide range of external and internal factors, and these can influence the skin singly or in combination. Therefore, the categorization of eczema is usually exogenous or endogenous. These are examples of endogenous causes of eczema, and in this lecture I'll speak about atopic and seborrhoeic dermatitis. These are other examples. Exogenous eczema includes irritant contact dermatitis, allergic contact dermatitis, infective dermatitis, and photoallergic contact dermatitis, as well as dermatophytid dermatitis. So in this presentation, like I said, these is what I'll present on. Now, atopy is said to exist when there's a personal or a family history of eczema of a particular distribution, asthma or hay fever, and many people call it allergic rhinitis. Atopy starts in infants and newborns between the ages of 2 to 6 months. The rash occurs on the cheeks and increases, primarily involving the chest, face, scalp, neck, and flexor extremities. Note briefly that the anterior knee is the location in infants, as opposed to in childhood. You'll find it on the posterior aspect of the knee, which is called the flexor fold of the knee. Here's an image of an infant's ankle. As you can see, the rash is on the flexor crease of the ankle, and here you can see the rash on the cheeks. It may be cute or look like a blush, but it's a symptom of atopic dermatitis. Now, seborrhoeic dermatitis. The infantile seborrhoeic dermatitis occurs within the first 3 months of life. The onset is usually at 6 weeks and it lasts approximately 6 weeks. It does not itch and it affects primarily the scalp, and this instance is called cradle cap, the ears, the eyebrow, and the diaper creases. Irritant dermatitis. Common irritants in irritant dermatitis include alkalis, acids, chlorine, bleach, strong detergents, and disinfectants. And important to note is that irritant dermatitis spares the crease. And think about it. If the crease is where the skin folds onto each other, then it serves as a protection to any irritant that may touch the skin. And this is why in irritant dermatitis, the creases are spared. These are examples of common irritants. Other than the acids and the alkali and the bleach, these other things can irritate the child's skin. So you need to look out for any of these irritants if you're suspecting that it's an irritant dermatitis. Diaper dermatitis. So there are two types of diaper dermatitis and they can happen at the same time. There's irritant contact dermatitis and candidal dermatitis. Irritant contact dermatitis is the most common cause and it occurs on the prominence of the skin of the buttocks, the perineal area, the lower abdomen, the inner thighs, the skin creases are relatively spared because it's irritant contact. In diaper dermatitis, the irritant is usually the proteolytic enzymes that are found in feces because it comes out of the intestines, and irritant chemicals in the face of excessive heat or moisture. Friction may aggravate it as well. And candidal dermatitis occurs because of an infection with Candida albicans, which is a fungus. The treatment of irritant contact dermatitis is just to lessen the exposure to the irritant. So frequent diaper changes will lessen the exposure to these enzymes, and washing the diaper area very often and leaving the child's buttocks to air out instead of keeping it in a diaper can lessen the chances of the child getting an irritant contact dermatitis. You can also use diaper cream, which is very often used to prevent this. Now, in terms of the candidal infection, this begins in the creases and spreads to other surfaces because Candida albicans is one of the normal flora in the genital area, and it thrives in hot, moist areas. So in the creases, there tends to be a lot of sweating. If the child urinates on a full diaper, the urine will sediment between the creases instead of going out on the skin. So this is where the organism would flourish and spread from the crease outward. It may be associated with oral thrush, which is caused by Candida albicans. The rash appears as a bright red, beefy, sharp, raised borders and small satellite lesions, which are made of papules, vesicles, and pustules along the margins. Scales may be located along the edge, and Candida albicans can be a secondary cause of infection or a primary cause. So, like I said, in irritant contact dermatitis, the proteolytic enzymes can basically work on the skin and cause erosion of the skin. And because the child loses the epidermal layers, protective layers of the skin, it predisposes the child to getting an infection from the Candida albicans fungus. This is secondary cause of diaper dermatitis, but a primary cause is where the child just has a Candida infection, starts in the creases and extends to cause the diaper dermatitis. Candida infections can be treated with nystatin cream. Now, oral thrush. This is caused by Candida albicans fungus, and you will see white creamy plaques on the buccal mucosa, the mucous membrane of the mouth, and you can also see it on the tongue. The difference between oral thrush and milk stains in the mouth is that the oral thrush is hard to remove when you scrape it, and when you actually get to remove it, it may cause bleeding. And here's a picture with Candida infection. As you can see, there's a circular white plaque, creamy white plaque, and this is just one of the clusters of the infection on the buccal mucosa. It's treated with nystatin suspension, 100,000 units, 4 times daily for 10 to 14 days. Now, neonatal varicella. Neonatal varicella is usually seen in the context of maternal chickenpox, or more rarely, varicella zoster virus, or of contact with an infected sibling. So you should be careful not to let the child be exposed to siblings who actually have chickenpox. Just try to keep the child far, far away from these siblings. Rapid diagnosis can be obtained by specific immunofluorescence of the vesicle fluid. Neonatal varicella resulting from perinatal transmission can be life-threatening, and if severe, it will require intravenous acyclovir. Petichiea. These 3 diseases will manifest as petichea or petechial rashes in children, vasculitis, inflammation of the blood vessels, meningococcaemia, and thrombocytopenia. Thrombocytopenia is the most common cause of petichea in infants and newborns. Here's a picture of vasculitis in an infant, and here's a picture of the meningococcaemia. This illness, meningococcaemia, has basically been eliminated because of the use of vaccines. It's usually caused by meningococcus B or C, and the vaccination schedule, according to CDC, Center for Disease and Control, is for preteens and teenagers to get between the ages of 11 and 12, and a booster dose is given at 16 years old. Thrombocytopenia. This is a picture of a child with thrombocytopenia, and in terms of this, it's usually caused by platelet destruction by maternal antibodies or from a congenital infection such as cytomegalovirus. Congenital rubella is extremely rare because of immunization, but if the mother wasn't properly vaccinated, that is, if they didn't get the booster of MMR at you can expect the child to get rubella infection. Here ends my presentation. I thank you for watching. I hope you have learned something. And if you have a child who's suspected of having a rash, please seek medical help so that they can actually treat the infection. Thank you so much for watching. Please subscribe and like.